One of them is, are physicians being trained on the point of care ultrasound? Russell?
Yep. So I can take that on. So the answer is yes. What's really interesting about training as it relates to point of care ultrasound is that it's really simple. So it's not years worth of radiology training and fellowships and all of that we need to go through. It's actually pretty simple. So we're working with the company. The company's name is Butterfly, and lots of online modules that are available, but also on-site training that we've made available, and pretty short courses at that. So depending on the proficiency level, we tailor them with these specific courses. So physicians are loving it with very little training. If at that, they're able to go in and start utilizing the devices. What's also interesting is that I mentioned AI. So there's AI algorithms that's built into many of the presets as well. And much like your iPhone, there are updates and newer algorithms that are pushed to you as well. So that makes it easier. That helps you, especially for a non-radiologist, helps you with some of the more complex type of or imaging type procedures. And there's also teleguidance. So someone could be guiding you virtually from another location as you're doing this ultrasound, leveraging the point of care ultrasound device.
There was another question that was also, how did telemedicine help in New York? Was it used for tracking?
Let me make a statement about telemedicine more generally. I would not, let me separate out how physicians and hospitals use telemedicine from the public health departments. Contact tracing is really the responsibility of the state government. And so they have tools they use to communicate with people and to track them, investigations, if you will, about who and how they've been in contact. I would imagine the telemedicine use cases, Rasu, you could probably speak more about them, but I'm going to guess that for patients that are at risk of disease progression that can't come into the hospital, they're using this. Ross, so you could probably finish the statement. What else are you seeing on these?
Yeah. So a lot of things there, synchronous, asynchronous type telemedicine events. So, we're doing a lot of things right now in terms of teleradiology, but the most simple one was telephonic visits, not even video visits, but telephonic visits. And that was one that saw a big spike up with, us going into the COVID-19. So both in New York and our institutions here across the Southeast, that was what was the biggest spike up, was just telephonic visits. But the video visits element went way up as well. And but the other thing that's going up, and this is primarily as a result of some of the billing codes that are being turned on right now, are remote patient monitoring. And I think that's a really promising element of telemedicine moving forward. That I think will be sustainable in the post-COVID-19 era, where we'll be monitoring patients from home, so much like the virtual hospital at home program that I talked about earlier. We now are actually going to be paid for some of these specific billing codes. So that's really exciting as well.
If I may, Archana, I see a question that I was keen to answer. Pankaj is asking, do we know the demographics and comorbidities that correlate with COVID mortality? The unfortunate reality is we are relying today on Wuhan and other Italy models. US models of mortality prediction have not really had the opportunity because we've not been able to assemble the data. It's not been published yet, and that's sort of a little bit of why I made a little joke on the chat, although this is obviously not funny. But the VA just shared verbally some early results on veterans, and they looked at factors that drive mortality. Obviously, number one is age, so that's obvious. Multimorbidity is also relatively obvious for the folks who dig into claims data. The Charlson Comorbidity Index scores of 8 would be a factor. But it turns out smokers and non-smokers are equally at risk, but former smokers are considerably higher risk. Former smokers. And also odd, if you drink a lot, you have lower risks of COVID mortality. So there's some very interesting factors that are coming out. And Pankaj, I don't know, 14x mortality is not what was published. So this is an area where the data needs to be more transparent. And unfortunately, we lack it. The public health department just basically knows the minimum in the case report forms that are phoned and faxed in. In Chicago, I am advising the governor's office, the mayor's office. Pankaj, your experience at Kaiser would be different than the experience at the VA. Isn't that sad? You're able to see the integrated data in your environment. They share the exact opposite on their presentation to the FDA this week. And this is the frustration. You have a sample, they have a sample, and it's completely different on the outcomes. And so that's an unfortunate circumstance, Pankaj. He's describing here that Kaiser's got a database to track it, and we're not seeing the same factors. And the reason this is frustrating is we're trying to aim as many limited resources to get folks quarantined, stay at home, and et cetera. And if we don't have the right outreach plan, we may miss the mark, and that's one of the frustrations. But back to my statement about the Chicago, the mayor's office declared that EHR records are the minimum data necessary for public health investigations. And now in Chicago, they have aggregated 50,000 medical records for patients that have COVID positive or negative, and they're beginning to comb through it for these sorts of factors. So that, Pankaj, in your example, that would be Kaiser sharing it with the local health department, pooling it with the other health systems, and then publishing their own investigation reports.
There's another question here, which is a little different. How much has the lack of initial testing hampered what we know about COVID, and how do we safely move forward from here?
For to Rasu, I mean, we are all in the same boat. We should be doing more testing in order to understand what you need to do to make incremental decisions. A massive decision like shut down the entire economy for 2 months, that's a big blunt instrument. We're going to move into a phase where we're going to have these more surgical interventions. When does Atrium decide to do elective surgeries, as an example, Rasu? Maybe you could talk a little about how you're thinking about the judgments that have to be made at the micro level.
Yeah, no, absolutely. So we were late as a country to start, testing, and we continue to be late in terms of the mass testing that needs to be happening right now. You might have heard that Wuhan is testing everyone across their communities right now, and there are many countries internationally that are doing that, but not in the United States. So we're late, and I think every day that we're late, what we've lost is opportunity to really get ahead of this. And as a result of that, we are where we are in the United States today. One of the things that we've done at Atrium Health is to try to, work against the tide and to do as best as we can to manage, the testing elements of this because we have our own lab. So we've got a fully functional lab internally. We were a little strapped initially because of the reagents that were lacking, and we had to depend on supply chain efficiencies to get that in place. But that's my reaction in dismay to sort of the state of where we are in the United States as a result of our lapse in really jumping to the opportunity to test. Anish, just on the electives, we've actually started to turn back our electives in a very thoughtful manner right now. So we're starting to see our volumes start to bump up, and so specifically, having targeted outreach to patients that are more critical, that need to come in. So for specific procedures, and so we've started to see that, and that's going to be ramped up in the next couple of weeks as we move forward.
I've seen that you guys have been answering a lot of questions on the side as well, which is really good. There was a question about telephone visits being reimbursed in the future. Will that still remain?
Certainly hope so. I think the genie is out of the bottle, and we're starting to have a lot of those conversations both at the state level as well as at the federal level, and a lot of the conversations that I've been having indicate the fact that payment parity will continue after this pandemic is behind us. It's also a culture change issue. It's not just one of policy and regulations. And what we've seen is there is a tremendous demand from consumers who've gotten used to this. And then same thing for the clinicians as well. Even the most technophobic clinicians were pleasantly surprised when they were able to do telephonic visits to their patients as a result of the restrictions that we put in place around COVID-19. And they were chatting with me and saying, "Hey, Rasu, this is actually pretty efficient, and I'm able to check on so many more patients as a result of this." So there's this cultural element that I think also would add on to the element of that genie being out of the bottle that I mentioned.
A question for Rasu. Really enjoyed your talk. One of the new norms that we're seeing in the hospitals is a lot of the hospitals are relaxing some of the rules, the stringent rules that we've had. Do you see a time where some of the allied health professionals will be a little more, such as doing ultrasounds on the patients, or even dialysis technicians and so forth, using the ultrasounds and feeding the information to the treating physician or surgeon?
Thank you, Srinivas. That's a great question, and it's one that hits home as a radiologist, because there's always turf battles going on across various groups, not just within departments, but also, like you said, between physicians and allied health professionals. The answer to that is yes. I think there's going to be more and more where PAs and others and allied health professionals, as you put it, will continue to eat into some of the things that we as physicians were or have been doing, primarily because it's just more of an economic equation than anything else. And I think what's important is for health systems, whether it's hospitals or clinics or otherwise, to closely monitor that movement to make sure that what's happening there still maintains the quality as well as the outcomes to the level that we would expect as a health system overall. But the reality is that if you look at anesthesiologists, right, PAs were able to go in and and there are arguments to be made on both sides, but in large parts, PAs were able to take in and do some of the the more mundane, I would say, type of tasks that were being done by anesthesiologists. But we're starting to see that in other areas, ED physicians, even primary care physicians and others. So that battle will continue on. I think personally, it's important for physicians to monitor that carefully, and there needs to be more of a collaborative care approach around the patient, with the patient in the center. But I think this is less of a policy or even a hospital decision in terms of how we do things, but it's more of an economic decision.
Thank you.